Happy to have Julie here. She's the immediate past president of the International Geriatric Society, and she's going to talk about how we maybe can help these geriatric patients a little bit more.
Thanks. This is which one of these talks is not like the other. So the previous talks were great in terms of showing the problem for some of our pelvic fracture patients, and also a really innovative, exquisite solution. Like, I think the CurvaFix technology is just brilliant, not just for pelvic fracture fixation, but I actually can envision a lot of other applications for it. That's not what this talk is about. I'll be brief, but what's happened to me in the course of my practice is that when you talk with geriatric fracture patients, what they complain about, or what patients and families complain about, is what happens to them when they're not admitted to the hospital as inpatients. Rather, they're admitted to observation status. And that matters a lot for folks in their recovery and the financial burden of their recovery. So we looked at that and essentially wrote an opinion paper about it that was published in 2020. All the cases that were shown this morning, I think that the indication for CurvaFix was just brilliant. I mean, I think that you can see how a curved implant that then becomes rigid makes sense in those patients. But the population of pelvic fractures in older patients is huge. We as orthopedic trauma surgeons actually don't see most of those patients because most of them are treated non-operatively. And one of our opportunities is to actually figure out in whom these innovative implants are indicated. I know it's heretical in this setting, but I don't actually think of most of our geriatric fracture patients as commensurate with hip fracture patients. Many of them are, but most of them aren't. LC1 fracture patients treated non-operatively, about 30% of them start to use an assistive device for ambulation that they weren't using before. In hip fracture patients, 70% do, and these are folks who were fixed. So we just, I think, have to get our hands around our indications for this technology, because this is regardless of what happens to us. Even successful aging looks like a declination in stamina, endurance, and physiologic reserve. These little bumps are fracture or some other major pathophysiologic event. Anyway, pelvic fractures represent approximately 5% of lower energy fractures in the elderly. And even though we aspire to and talk about folks going home, almost no one goes home. If you have a patient who goes home, that's awesome. But if you actually study these patients, almost no one goes home. And that's okay, because at skilled nursing facilities, they get skilled nursing and physical therapy. But I don't think we should kid ourselves that most of these folks are going to go home regardless of what we do. Or if you study it, I want to see you publish it. Like, where are these folks going? It's not a failure to go to a skilled nursing facility. It's a failure to not be mobile and have your comfort controlled or your pain controlled. As Daniel mentioned, the mortality rate's around 10 to 20%. Of course, in some studies, it's less than that. And in some studies, it's more than that. It depends on the fracture pattern, I think. And a lot of the data we have, there is not a good description of the actual fracture pattern in these folks. We call them fragility fractures of the pelvis, but we don't delineate anterior or posterior ring disruption. And only about 20% receive the kind of care that Daniel was describing in his patients. And that's a real opportunity for us. So as I mentioned, I was interested in understanding what mattered to these patients. I think if you're in the US, you probably have heard of the 3-day rule. And if you're admitted to the hospital, but you spend less than 3 days in the hospital, and you are then discharged to a skilled nursing facility, Medicare doesn't pay for it. And that's a huge financial burden for patients and their families. The difference between the cost of an inpatient stay and skilled nursing stay is about $1,500 on average. But what happens is that many of our patients who have this injury don't meet criteria for admission as an inpatient, but they can't go home. And so they're admitted as an observation patient, and then when they're discharged to the care facility, they end up paying out of pocket for their care. If you stay 3 days in the hospital, Medicare pays 100% of your skilled nursing facility for the first 20 days and 80% after that. There was one successful model. This was from Cleveland Clinic. They only had 12 patients, actually, but what they did was they identified these patients, sent them to a skilled nursing facility directly because their insurance allowed for that. And in these patients, these were non-operative patients, none was readmitted in about a 6-month period. I think that it's great as orthopedic trauma surgeons to think about and execute the best surgical care when indicated in these patients, but we ought not to forget our partners in the care, which are our geriatricians, hospitalists, dietitians, and other folks. Because we may make a difference with our choice of implant that's, 5%, 10%. But if we also ignore that they don't have good nutrition, or if they're not really getting out of bed with physical therapy or having a reasonable attempt at it, I think we're really missing an opportunity. And there are definitely papers out there that show that operative fixation of low energy pelvic fractures makes a difference in terms of mortality. But there are also a lot of papers out there that show that non-operative treatment has somewhat commensurate outcomes. Now, I believe in this technology for certain patients, but I think our challenge is to determine who those patients are or to understand the best indications for the technology. And in the randomized controlled trials, there's one that's starting in the Netherlands. There's, I think, one in Germany. I know Brett is spearheading studies here in the US. I think the most important question has to do with timing. When the decision is made to go from a non-operative treatment course to an operative treatment course, and fracture pattern. Fragility fractures of the pelvis are often lumped together as one entity, but actually understanding the fracture in the patient and then deploying the correct treatment is what I think makes our care most powerful and impactful. We did a little study a few years ago on hip fracture patients, and we were just asking patients what matters to them. I won't go into the details, so we'll have time for questions. But when you really ask patients what matters to them, it's their independence, it's their mobility, it's their, and it's whether or not they feel as though their care team is communicating and whether or not they have coordinated care. So I think it's really important to figure out what's the best technology for surgical care in our patients who need surgery. And yet for these patients, it's great to talk about, the patient went home after a day, they went home, they don't use an assistive device. And those are definitely some of the few patients, but there is a huge population of patients out there for whom operative fixation is probably not indicated, and the greater we understand the natural history of the different types of fragility fracture patterns in the elderly, the better we can do at providing best care. Thanks.